The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Fantastic. Thank you so much. And thank you, everybody, for joining me across the country where we talk about this important and extremely under-recognized topic. You know, just if you take into consideration the fact that one of the most common causes of erectile dysfunction is not only diabetes, but also prostate cancer. These are things that are extremely prevalent in our medical community. But the thing that nobody really talks about are the sexual health manifestations that go along with not only being a long-term diabetic, but also a survivor of prostate cancer. I mean, if you just look at the numbers, prostate cancer is an extremely curable disease if caught early. And so therefore we have a lot of prostate cancer survivors that struggle with these issues. So, you know, I think this is a fantastic moment to kind of educate ourselves on some of the options that exist when pills, Cialis, Viagra, and the like are not effective. So with that, let's go ahead and get started. So we'll certainly cover erectile dysfunction, what it is, what causes it, and what's the mechanisms behind it. So erectile dysfunction medically is defined as the inability to achieve and maintain an erection that is necessary for sexual activity. And the breadth of this problem is huge. You can see on the slide here, you have 50 million men on average every single year that are diagnosed and being recognized as men with ED. And not only that, but we're seeing that the numbers are becoming younger and younger and younger. 40% of men have some sort of ED syndrome by the age of 40 years old. And most of this leads to negative impacts on their quality of life. Men who have this often have comorbid issues with depression, anxiety, and other mental health issues as a result of their condition. And so while ED is common, unfortunately, the breadth of medical treatments that we have available is not. So with that, as I was mentioning earlier, diabetes and prostate cancer make up significant members of individuals who have this. If you think about the causes of erectile dysfunction, in order for there to be the proper sexual activity, you first need to have desire. So what governs the desire is oftentimes that of a hormonal balance. And so that starts to get into, as you see on this slide, men with either low testosterone from an endocrine perspective or psychoactive medications that are commonly given for depression and anxiety oftentimes interact negatively on a man's libido, accounting for the medication. So that's the first step in the sexual cycle. The next step in the sexual cycle is to be able to have the neurologic impulse that's transmitted from the central nervous system down into the genitals. And so individuals who either have a spinal cord trauma, multiple sclerosis, some sort of accident, stroke, that's going to cause there to be an interruption in the signaling pathway leading to the neurological causes of ED. Those are fairly rare. By far and away, what you see on this slide and what we see in clinical practice is the most common causes of ED are that of vascular, whether it's from diabetic or cardiovascular. And that's simply the mechanism where the body may have blood supply that's going to other organs, but because of diseases where the blood vessels cannot transmit the blood into the penis, that can result in either situations where the blood cannot arrive in the penis at all. We call that arterial insufficiency, meaning that the penis is calling for blood to arrive, but as a result of damage to blood vessels, it's not able to make it. Or that there is the inability for the blood to trap it once it arrives. So a vascular problem could either be an inflow issue where the blood doesn't arrive, or an outflow issue where the blood arrives, but it leaves too quickly and it's not able to be trapped. And vascular ED is by far and away the most common cause. And that's what we're going to talk tonight about, these therapies for vascular ED. So ED has a whole host of psychologic effects. Oftentimes, patients that come into my office report issues with, depression, anxiety, feelings of decreased self-worth, frustration in themselves for not being able to satisfy their partner, issues with insecurity, and frank embarrassment. It's a very difficult conversation for patients to even be able to bring up to their healthcare providers. If you look at studies in terms of the psychological effects of ED, 50% of patients will report a negative impact in their daily life, and a large amount of these individuals report issues with intimacy and lower confidence. So it's certainly something that goes beyond just the mechanism for why they have the ED. There's a lot of issues that then come about as a secondary side effect for this. So the erection process. So as I was kind of inferring on the previous slide, the sexual cycle is a very complex situation where you first need to have an arousal that is usually governed by your sexual appetite, or your libido is what we call it, that then in the right circumstance, and by the way, in the right mental mindset, you have to be in a good situation with your partner, you have to be in a good financial situation, you have to have plenty of sleep, things have to be going well at work, low stress environments. All these things are also very important to the sexual cycle. But when you have the arousal and the time is right, so to speak, the nerves have to transmit the signals down into the penis that then cause engorgement. And the way that occurs is because you have smooth muscles that are around the arteries of the penis. And when those smooth muscles relax, it then causes there to be an inflow. Now, of course, we were talking about arterial insufficiency earlier, and that occurs when there's damage to those blood vessels. So either the muscles are not relaxing so that the blood cannot come in, or that the actual artery itself is what we call fibrotic or sclerotic, which just basically means rather than expanding and contracting with elasticity, it's rather stuck in its way. So even though the muscle might be relaxing, the actual artery doesn't open to allow there to be more blood flow. But then once that occurs, then with adequate blood flow, the penis then becomes erect and stiff. And as a result of the stiffness, that secondarily compresses the veins that would otherwise drain the penis. And so then therefore it allows the penis to maintain erection. So how do ED medications work? So if you've identified the problem and the mechanism, then it's a matter of then pairing the appropriate treatment. So we'll talk about advanced options for vascular ED, which is what this talk is about. But to kind of take it back a step, you have to know the mechanism. So if it's low testosterone, you fix the low testosterone. If it's a neurologic issue, unfortunately, those are a little bit more challenging unless it's the case of like a multiple sclerosis where you take an immune suppressant. But if you're in the situation where it's a vascular problem, then unfortunately there doesn't really exist a medical technology in terms of to surgically build new vessels. So what we're trying to do is we're trying to use these medications to augment the blood flow. And that's usually the first step. So when a patient sees me for a new consultation for ED, usually one of the things, if not primary care, has already tried something like a Viagra or Cialis. And the way that these medications work is it takes the blood vessels that are not diseased and still healthy inside the penis and tries to make them work on overdrive so that they can then compensate for the loss of the damaged vessels. But unfortunately, if the vascular damage is too substantial, there's situations when those medications don't work, and then therefore we progress onto either injectable therapies or penile implants. Who can you see about this? We have kind of identified that there's the nature of this problem. It is a complex problem. Oftentimes, us as urologists will work together with primary care doctors who will usually at least start an oral medication by the time that they issue a referral. But ultimately, what is important to know from a patient education standpoint is you really want to see somebody who is in your area that has specialized expertise in prosthetic urology. And because that goes hand in hand with other treatments with ED. Oftentimes, as everything in medicine becomes more specialized, if you just go to see a general urologist, sometimes that urologist may be specialized in stone disease or cancer. But there are a subsection of us that have specialized training in prosthetic urology and in ED and in men's sexual health, and those are the individuals that you want to target. And there's a lot of different ways that you could find those individuals. For example, at the beginning of the talk when I was introduced as a Coloplast Center of Excellence. So if you go onto the Coloplast website, you could find individuals like myself who are centers of excellence for these types of not only surgeries for implants, but also consultations for ED, and be routed directly to those individuals as a nice way kind of to shortcut that system. If you were to see me in the office, you're referred by primary care, and you're seeing me because you've tried 100 milligrams of Viagra, 20 milligrams of Cialis, or even both in combination, and things don't really work, what are kind of our next steps? And that's what we'll talk about. My go-to is to talk about both injections and penile implants. So the way that I like to introduce this to my patients is that injections are kind of like a very, very potent Viagra. So one of the problems with Viagra, Cialis, or an oral medication is that it's a pill. So you have to take a pill, it has to be digested by your GI system, and then that 100 milligrams of Viagra is going to be spread out through your whole body. Some percentage will go to your brain, some percentage will go to your heart, some percentage will go to your muscles, your limbs, etc. But when you're dealing with an injectable, 100% of the medication will go into the target. And that's really the advantage of the injectable medication. They work in terms of a similar mechanism of action to Viagra. It's just that you, number one, have 100% of the dosage, which allows us to dial up the concentration. So the reason why, Viagra is going to be capped at 100 milligrams is going to be because there are side effects that are associated with this. Some of you guys that are joining this webinar today may say, I've got facial flushing with the Viagra, nasal stuffiness with Cialis. Sometimes it drops the blood pressure. So when you hear, on the commercials, if you take nitrates for chest pain concurrently, you can't take this stuff. And it's because there's cardiovascular implications because it's a pill that circulates through everything. And that's why the dosages are capped on where they are. However, when you're dealing with an injectable, truthfully, the sky's the limit here because all of that medication is going into the target and it's staying there. There's not much systemic side effects that we see with this stuff. And that's why individuals who are deemed not safe to take these oral pills because of concerns with interactions with blood pressure medications, they often have really good success with the injections due to the fact in which there's no real drug-drug interaction with those other oral medications. And that's really a good advantage to the injectables. However, there are situations where the vascular damage is so substantial that not even injectables work. And then that's when we start really talking about penile implants, which is a mechanical replacement for our natural erectile mechanism. So let's specifically talk about ICI, which is the abbreviation for intracavernosal injections. How does this work? So it works by having a mixture of components that are what are called vasodilators. So a vasodilator is something that causes a blood vessel to expand. And when you think about the mechanism anatomically of how an erection is generated, it first starts by dilation of those arteries. And so these medications, when injected directly into the penis, act upon the smooth muscle that surrounds the arteries to cause that to relax and cause the dilation of those vessels to occur. When you have the dilation, then you get more blood that comes in. And like I said, there's a very complicated microvascular network inside the penis. And so even though you may have some vessels that might be damaged as a result of your ED, whether it's from diabetes, prostate cancer, cardiovascular disease, the blood vessels that are not impacted and are still healthy are able to use this medication to then dilate. And so there are different formulations of this. So usually when it comes to injectable medications. There's single agent, double agent, triple agent, quadruple agent, and those are more aptly named. Single agent is known as called EDEX, or that's just single agent alprostadil. But that hasn't been really effective. We've noted that by adding additional vasodilators to this mix, it increases the effectiveness. So when you do bimix because there's two, that's papaverine and phentolamine. Then if you add the EDEX or the alprostadil component to the bimix, now that's 3 components, that becomes trimix. And then when you add atropine to trimix, that now becomes quadmix and 4 components. And so it really just depends upon patient circumstances. What is the right mix for you? That usually depends upon what is the degree of your erectile dysfunction. I'll note that one of the things that's important about these mixes is that they usually have to be refrigerated. So when you order these things from menMD, in the package, they come with insulating packages. And that allows, when you have things like trimix or quadmix and you want to take that with you on vacation or to a trip, you want to use these with an ice pack inside, because the trimix and the quadmix needs to be refrigerated. It's one of the advantages of the bimix, that even though it's a little bit of a weaker constitution because there's only 2 ingredients, it does not have to be refrigerated. So for individuals that travel a lot, if this is a mix that works well for you, it's also pretty good from a lifestyle perspective as well. So the medication concentration. So not only can you change the mixture, whether it's the alprostadil alone, whether it's bimix, trimix, quadmix, you can not only change the number of components, but you can change the concentration of the mix. So there are weaker trimixes, and there are things all the way up to super trimix. And that's why, when you meet with, somebody who is well-versed in these treatments, we can not only tailor the number of components of the mix, but the concentration of that to a patient's specific needs. So it ranges anywhere from the weakest, which would be the lowest concentration of just the EDEX, all the way up to the highest concentration of the quadmix and anywhere in between. How do you do this? So they're called intracavernosal injections, and the way they get that name is because if you look on the lower right-hand part of the screen, if you were to take a cross-section of the penis, there are these 2 chambers, and you can see them on the top. They're called the corpus cavernosa, and those are the chambers that are responsible for erections. They're basically networks of blood vessels, arteries, and veins that are contained within a fibrous sheath. The chamber on the bottom, as you see, is the corpus spongiosum that contains the urethra. That is not involved in the sexual cycle, but it's important to know where that is, because when injecting yourself, you want to inject on one of the sides so that you go into the corpus cavernosa. So, for example, if I were to show on a model here, so if this is the penis straight ahead, you want, when you use an injection, you want to inject on either one side or the other. And that comes from, when you look at the cross-sectional diagram, the 3 or the 9 o'clock positions on the penis is going to allow that needle to go straight into that corpus cavernosa, and that's how these injections are called intracavernosal injections. Conversely, you don't want to inject on the very bottom of the penis, because that's where the urethra runs. And then when you also look on the cross section, all the big blood vessels as well as the nerves, they run on the 12 o'clock surface. So you don't want to inject on the bottom. You don't want to inject, on the top or the bottom, because that's where your critical structures run. You want to go on either the right or the left side. It's important to know that even though you don't see it in this little cartoon, there's cross-communicating vessels that connect the left corpus cavernosa to the right. And so therefore, you only need to inject one side or the other. You don't want to do both. That will cause you to have too much medication that's delivered inside. Also noted on this slide is we talked about things like storage, so these things should be refrigerated, not necessarily so critical for the bimix, and usually they're to be discarded after about 1 month. Now, I have patients of mine that use them for longer than 1 month. that's okay. It's just that the medication will lose its potency if you inject it that's a little bit later past that timeline. Common side effects of this. So one of the things that I commonly will tell my patients is to move the site of the injections around. We talk about the anatomy and only the need to inject one side or the other because you don't want to inject the same site over and over and over again. One of the things that we can see is if you commonly only inject one site constantly, you can get Peyronie's disease, which is a little bit of scarring that can occur at that injection site, and then that can cause angulation of the penis in the direction where you've injected. So I will usually have my patients switch, if Monday it's the right side, then Tuesday the left, and vice versa, so on and so forth. And then it's important to know to inject only one side or the other because priapism is a real concern. So priapism is well known in the community by when you hear any commercial for erectile dysfunction, they'll say, if you have a sustained erection for more than 4 hours, seek immediate medical attention. And that can happen if you overdose on these things. So if you double the dose that's intended by injecting both sides, if you inject too much, that can cause a priapism, which is a painful erection that is sustained and that does have to be seen in the emergency room. Otherwise, it can cause permanent damage to the penis. So following the directions of your healthcare provider for these injections is very important. Intracavernosal injections are what I consider to be maximal medical therapy. There's really no stronger medications than this. And if individuals have poor results for the intracavernosal injections, that's when we start talking about penile implants, which is surgical therapy. Penile implants are a long-term, durable, yet mechanical solution to the problem of ED. What they are is it is an implanted device that allows a man to achieve an erection on demand for however long that one person desires. Everything is completely internal, so it's discreet. If anybody looks at you, no one would know that you'd have it. And one of the big advantages of a penile implant is that it gives you spontaneity. Oftentimes, one of the complaints that I have about my patients who either use injections or pills is that they have to plan their sexual schedule around these things. Injections, usually take only about 5 or 10 minutes to kind of kick in. So it's something that has to be given on demand while you may be, kind of in the middle of introducing sexual activity. So there has to be a pause in the action, so to speak. But with a penile implant, you could generate the erection on demand without a loss of spontaneity. And I think that is a good, reason why a lot of men desire this. Usually it is about a 1-hour surgery. It's considered to be ambulatory surgery. All my patients go home from the recovery room on the same day. And it's usually a healing process that takes place in about 4 to 6 weeks, where once the implant is placed, we just allow our patients to heal. And then around that timeline, we show that individual how to use their implant. The nice thing about these surgeries is that when shown to be coded under certain medical conditions, like a sequela of prostate cancer therapy or diabetes or cardiovascular issues, especially in individuals where we tell the insurance company, we've tried pills, we've tried injections, we've tried vacuum erection devices and all these different sorts of things. Usually insurance companies are very receptive to having these surgeries covered at no cost or at little cost to the patient, which is also a huge advantage as well. So there are a couple of different types of implants. In general, there are malleable implants and there are inflatable implants. Most individuals opt for inflatable implants due to the fact in which it is what mirrors our own natural mechanism to the greatest degree. And so what it is, I have a model here, but you can see it on the screen. So a penile implant is a multi-component system. Okay, so you could follow along with not only the implant that I have to show, but also the little cartoon that you see. So The way that this works is that you have these two implant cylinders that are placed inside the shaft of the penis, okay? And those simulate what are called those erectile bodies, the corpus cavernosa. So what happens is that you have a small pump that's placed inside of the scrotum. And when you squeeze the pump, every single time I squeeze the pump, it's going to put more and more fluid into the implant. And what you're going to see is with every squeeze, there's going to be more and more fluid that's going to generate an erection. When everything is all said and done, there's a deflate button that's at the top, and you press and you squeeze that for a couple seconds and let go, and little by little, the fluid is going to drain out of the implant cylinders. It's going to be returned into what's called a reservoir or a holding tank. As you see on the diagram here that's placed deep inside your pelvis, it just holds the fluid for the system. So one of the advantages of this is that in a mechanical fashion, it inflates, deflates, inflates, and deflates, hence why it's called the inflatable penile implant. When it's deflated, it mimics the flaccid feel, and when it's inflated, it mimics the erect feel. And so just like intracavernosal injections in the right patients achieves a very high degree of satisfaction, so does the penile implant. The penile implant has been around for several decades. It's not a new surgery, just how we're on like the iPhone 16. It's underwent its subsequent iterations, and so the model that we have is very, very well known and very well studied. It has a amazing track record. These implants usually last 10, 15 years, if not longer, but it's dependent upon use. The way that I like to describe this to my patients is that very much like you have to change the brakes on your car because they wear out, nothing that's mechanical that undergoes wear and tear lasts forever. These penile implants, they have springs, valves, working parts, and so they do have a longevity, but certainly that is also a function of the frequency of use. They're very well known and studied in the medical literature to achieve high rates of patient and partner satisfaction, which makes this surgery the gold standard for this problem, especially in a situation where intracavernosal injections either don't work or are not desired for the patient as a result. For example, I have individuals that have a hard time mentally getting over the fact of injecting themselves, even though the injection may work very well. Sometimes there's phobias in needles and those sorts of things. So this is a instructional video of how this implant works. So what you're going to see here is exactly what we've gone over. So there is 3 components. There's the implanted pieces inside the shaft of the penis. There's the pump underneath the skin of the scrotum. It's kind of like a third testicle, so to speak. And then there is the reservoir that just holds the fluid. It's something that you don't feel. So when a man wants to achieve an erection, you feel the architecture of the pump under the skin, you squeeze it, the pump, and in doing so, you move the fluid from inside of the reservoir into the implant cylinders. That will now stay erect for as long as you wish. And then at the conclusion of sexual activity, you can see what's going to happen here is that the man is going to hold the deflate button with one hand. If you want to speed up the process, you could kind of squeeze the cylinders as you saw, and then that will achieve a flaccid state again. With what's called the Titan Touch model, you don't necessarily have to squeeze it. The pressing of that deflate valve will allow the fluid to automatically re-enter into the reservoir chamber. The second type of implant is one that's called a malleable. So rather than necessarily having the inflatable, what these are single insertable rods. So rather than having a pump and a reservoir, these malleable rods, they hold the penis in a semi-flaccid, semi-erect state. The advantage of this is that in individuals with poor dexterity, it allows them to be able to just bend the penis up towards their belly when not using that for sexual activity, bend the penis down and out from themselves when they want to use that. One of the disadvantages of a malleable implant is that it holds the penis in a permanent, semi-erect, semi-flaccid state at all times whatsoever. And so sometimes individuals may say that it kind of bridges the gap between like a flaccid and an erect state. Where do these things come into practice? These things come into practice in individuals with spinal cord traumas, individuals that have hand contractures and aren't able to reliably inflate their pump. It doesn't take much manual dexterity to bend the penis up and down. The counterexample to that in the ICI, the injectable, is that the kits that come from menMD have these things. They're called injectees. And basically what they are is they're contraptions where once you draw up the medication into the syringe, you can place that inside of this chamber to help to do your injections in situations where the dexterity is rather limited, like I said, from either a spinal cord trauma or from a hand contracture, an orthopedic injury, those sorts of things. So we do have ways to work around that, whether it's in the implant sphere or whether it's in the injections. Nothing is without its risks. Just like we went over the risks of priapism, risks of Peyronie's disease for the injectables, penile implants also have their own risks as well. It is a surgical procedure. So there are anesthetic risks that certainly sometimes will have individuals meet with a cardiologist or a pre-op medical doctor for a medical clearance and those sorts of things. But outside of the anesthetic risks, there are risks that are inherent to the procedure itself. There are always risks of bleeding and infection. Usually infection is one of the most feared complications of these devices. That occurs at about a risk of about 1%, meaning that if the implant does get infected, it usually has to be removed and then the patient allowed to heal, and then another one can be placed back in. It ends up being a very truthfully traumatic experience for the patient because now one surgery does become 3. Fortunately, it is something that is not seen very common. We are very strict in terms of what we call glycemic control amongst our diabetics, meaning what the A1C levels are, because there's been a lot of medical literature that showed that the higher the A1C, the more likely the infected with when an implant is placed in. So we have very strict protocols for this between A1C cutoff, between checking blood sugars with finger sticks in the preoperative area, as well as a multitude of antibiotic and antifungal medications that are usually given before, during, and after surgery. And all of those measures will act to minimize that. One of the things to know about penile implants is that when you go this route, there's no going back. When you have an implant put in, it permanently will fix itself into position into those corpus cavernosa, those chambers that we saw during the ICI discussion, and it will become a permanent replacement for those chambers, so that if the implant does stop working 10, 15, 20 years from when it was placed in, you would need to have another one put back in. You can't simply just remove it and then either return to injections or pills or something like that. You'd have to have another one put back in for sexual activity. Now that begs the question, especially if you're putting these things into a gentleman who's, 70 years old or so, they may not be so interested in sexual activity in another 10, 15, 20 years when the implant craps out. And that's okay. There's no ill consequences that come about by leaving a implant inside, even one that does not work. So there are plenty of information when it comes to penile implants. We have a patient educator tonight that will talk about their story with this surgery, but there's plenty of information that's available through Coloplast, who is the maker of the penile implant.
Up next, we have our patient educator, Bob.
Well, thank you, Dr. Amend. First off, that was terrific. I learned a lot. Very nice to hear some of that. And hello, everyone on the call. It's a pleasure to be here. As mentioned before, I'm a patient educator. My name is Bob Thomas. I'm one of 5 patient educators, actually, for Coloplast. And what you might ask yourself, what the heck is a patient educator? Well, a patient educator is someone who has been through not only the experience of a surgery and a penile implant, in my case, but also a patient who has been through all of the various stages that were referenced in the doctor's presentation here tonight, including going from pills to injections to ultimately a penile implant. So there's a whole story in and of itself around that. Patient educators are not medical people. We're not people that are going to give you medical advice, but we are people that can be a resource for you if you're thinking about an implant, if you've had an implant and have questions about comparing your experience prior to surgery and after surgery with mine or one of the other patient educators, or if you just want to hear any perspective from a patient standpoint regarding this whole process and penile implants. Again, we're not doctors, so we can't dispense medical advice, and we certainly will not do anything to try to sell you on any decision one way or the other. We're here basically as a resource to answer questions. And I would say I talk to an average of about half a dozen patients a week. Most of them are facing into the decision and have made the decision or planning to make the decision around having an implant. Many of them, however, are people that have had the surgery and say, hey, I got this now and I want to compare notes with you. So either way, we're certainly available for that. My contact number and my email are there. If anybody wants to talk to me about anything relative to a decision you're trying to make, please don't hesitate to text me and we can set up a time and go forward. I'll be in the 5 to 7 minutes I have here, I'll try to be relatively brief, but also try to cover some of the bases that we covered before from a personal perspective. So talk a little bit about how I came to have ED, what my treatment options were, my reasons for going to a penile implant, what my surgery and recovery was like, and how I feel about it now, 2.5 years later. So I joke to my wife that I might be in my early 70s, but my penis is only 2.5 years old. So we got to share that with you. As mentioned, I had prostate cancer, and I caught it early stage, so I basically had all of the options available to me. The field was wide open, and I wound up opting for radiation treatments, a series of 28 of them. And I did that because I was really trying very hard even then to avoid ED as a result. And I thought radiation might be my best option. And you know what? For a while it was. Actually, for the first year or so after my radiation treatment, I thought I dodged the bullet. But then eventually ED set in and it became increasingly significant. And I did the usual track that perhaps many of you are on this call, and that's I started with Cialis or Viagra. I went with Cialis daily dose at first because that seemed like the least hassle. I didn't have to worry about when I would take it. And for a while those worked, but even when they worked, there was always anxiety about when they wouldn't work. So, and there was certainly the fear that I don't want to start something I can't finish. And so that was always in the back of my mind when I used them. And eventually they, as I said, worked until they didn't work. I progressed from there to Trimix, and the Trimix worked really, really well. And I was happy with it up until the time that I probably overdosed myself and wound up in the emergency room with the infamous erection lasting more than 4 hours. And while I was there, a doctor, one of the emergency room doctors, said, "You ought to look at penile implants." And I had no idea what they were at the time. And so my first reaction was, no, I don't think so. I guess I had this mental perspective of an erector set or something like that. But once I started looking into them, I realized that, hey, this could be the solution. First of all, it takes away all of the need for pre-prep, whether it's pills, you have to remember to take them, whether it's shots, you have to, and I traveled a lot on business, you have to remember to take it with you, and you have to keep it refrigerated, all the things that the doctor mentioned. And so I looked at the penile implants, and they looked like, they had a very high satisfaction rate. All of the literature I read indicated that the satisfaction rate was as high as 98% for patients, and just as importantly, or perhaps even more importantly, that satisfaction rate was just about as high for their partners, which of course is very important and one of the reasons why we're all doing this. And so, again, I did a lot of research, but it was really what did it for me in terms of tilting me in the direction of a penile implant was some words that were mentioned in the previous presentation. One, spontaneity. I didn't have to worry about when or how I could achieve an erection or for how long. And convenience. Again, nothing to carry with you or worry about taking at the right time or anything like that. And so after a great deal of deliberation and also a couple of consultations, not only with my prosthetic surgeon, but also a patient educator, someone like me, I ultimately decided to have the implant done. I think my surgical experience was probably very typical. They all vary somewhat, but I think my trajectory was pretty typical. I had the surgery as an outpatient. You had in the hospital and out the same day. And for 2 weeks, I went home and basically just iced. And I'd recommend for anybody who has the surgery, frozen peas are the best thing to use when you're icing. They're malleable and work extremely well. But icing was very important, and I took occasional Tylenol. But even though they sent me home with some stronger pain meds, in my case, I never needed them. I would take the occasional Tylenol if something got a little painful in the first couple of weeks, but there was nothing that I would call a deal breaker in terms of pain. At 2 weeks, I went in for my first post-op exam. Basically, that was just to check out and make sure that everything was looking good, and all the vital signs were looking good. At that point, no sign of infection or any of those risks. So at 4 weeks, I came back for my second post-op, and that's when they started show me how to cycle it. Cycling is basically making yourself erect for at least 20 to 25 minutes a day, and then deflating yourself. And it performs two purposes, one of which was you learn to use the device, which isn't very hard. I found that to be pretty easy to learn. And I'm not a doctor here, so the doctor might correct me, but I think it's also important to start stretching the tissue, and we're exercising the tissue. That's healing at that point. Anyway, they said cycling was really, really important. And so I was really, really diligent and did that every day. In fact, and continued to do that, I'd say for about 4 months after surgery. At 6 weeks, I went back for my follow-up appointment. And actually, it was my last appointment because they said, unless something happens, you really don't you don't need to come back. And by the way, you're good to go. You can resume sexual activity and whatever you want at this point. And which I did, and we did. And I'm not sure how long the residual effects of the surgery, the occasional pain after sex, or the things like that, just little soreness. I'm not sure how long that lasted, but I think for the most part that was all behind me within 3 or 4 months. But the important thing is I was back to and my wife and I were back onto a normal sex life 6 weeks after the surgery. So as I say, I talked to a lot of patients who've had this surgery, and I think that tracks pretty well with the majority of the cases. There are outliers, and but in my case, in terms of who I've been exposed to, not very many. The final thing I'd leave you with is when I'm asked, would you do it again? My answer for me personally is not would I do it again. I wish I'd done it much, much sooner. When I think about all the time I fooled around with pills and the other remedies when this was available, I really think, boy, I could have done it sooner and had a more rewarding life. And I started to say sex life, but sex is an important part of life, but it's not all of life. And I can't say enough how much this did for me, not only physically, but also did for me mentally and emotionally. I believe that was referenced earlier too, but it's a very important point to make. So that's my story. I hope I didn't go too fast. Hope I covered most of the main bases. And if you have any questions for me afterward, happy to answer them.
Great. Thank you very much, Bob. We appreciate you sharing your experience navigating these challenging decisions. So thank you very much for your wisdom.
Fantastic. So one of the things that I really wanted to also cover that I think that Bob was alluding to is some of the patient decisions to do one or the other. One of the things that we do see with the ICI, which we'll kind of go over how to do it, is that you get some glands engorgement. If you look at on the penile implant, the implant goes inside the shaft, and so even though there's a great rigidity of the actual shaft itself, one of the things that the patient criticism about the implants is that there isn't glands rigidity. Sometimes individuals might take like a Cialis pill or something like that when they've had an implant to achieve that. But one of the things with the injection is because it's using your own body's natural mechanism, it will give rigidity to the head of the penis. So let's go over how you would inject yourself. So when you get the kit from menMD, it comes in basically, let's say, 3 main components. You have the actual medication, whether it's your Trimix, your Edex or your Bimix, whatever have you. You have alcohol swabs, and then you have the injectable needle. Included in the kit, like we talked about, is a thermal pouch, so you can travel with it. In addition to that, there's the auto injector for individuals that have a little bit of manual dexterity issues. We'll go over the injection precisely. And then also they give you a sharps container to responsibly discard the needles when they're done. So the way that this works is when you look at the syringe, and I'll try to kind of bring this to the camera, you can see that there's these numbers, 5, 10, 20, 30, 50, etc. That's going to be the volume that you inject, and that's what a healthcare provider like myself will tell you how much to inject. So the first thing that you do is you take your medication, you take your alcohol swab, you open your alcohol swab, you then swab the top of the vial to make sure that everything is nice and clean, and then you open your needle. You can see it's a really tiny, tiny insulin needle. You go straight into the vial, and then you inject to whatever volume. So, for example, I'm just going to draw this for demonstrations purposes up to a volume of 20. I like to go a little bit beyond 20 because inevitably there's a little air bubble that goes inside, and then I push the volume back to push that air bubble back, and you can see now that I've gotten to 20. So now I put this back in the fridge where that belongs, and then I go to the penis. And like we talked about, you want to do right or left side, one or the other, okay? You take your alcohol swab, you swab the side that you're intending, and then you go straight in to your intended injection site. So here I've injected onto the right side, and then you just squeeze the medication in, come out, you're done with your injection, and then you take your needle and you dispose of it responsibly in the sharps container. That's all it is. It's pretty simple. It's nice and straightforward. The injection will take about 5-10 minutes to kick in. One of the things that's important is you do have to be stimulated. You do have to be in the mood, and it's a pretty simple process. I think certainly one of the advantages about the injection over the implant is that, it uses your body's natural mechanism. So you do get that glands engorgement. Another thing that patients like about the injections is the fact that if they're high-risk anesthetic individuals, maybe somebody who's had a pulmonary embolus or, a heart attack or, has issues, pulmonary issues, COPD, et cetera, and they're of high anesthetic risk, this could be a good situation to avoid a surgical procedure. But this is how you do the injections. They're very straightforward. I have a lot of guys that do them. I think that individuals at first, have to kind of get over sometimes the mental block of doing the actual injection procedure itself. But I think that what all of my patients will eventually say is that the mental anxiety and the thought of it is a lot more challenging than truthfully what it ends up being. In my experience, it's not a very painful procedure. One of the components in the mix that's called a prostadil can sometimes give a temporary penile ache. Usually that gets better as your body gets a little bit more used to it. If it's a situation where that's an issue, we then remove that from the mix. And so you'd go from trimix that has L-prostadil, you remove that from the mix, and you can go down to bimix. So there's a lot of flexibility with these injections. And it does inevitably avoid a surgical procedure, which, as we talked about, does have its own risks. When it comes to the penile implant, we we're kind of going over that before previously, but you can see it now in full screen a little bit better. So on the board here, you have the components. So you have the reservoir that holds the fluid for the system. As you see on the model, this is placed deep inside of your pelvis. You don't see that, you don't feel that, that just holds the fluid for the system. Inside the shaft of the penis, you have the two implant cylinders, okay? And one of the questions that a lot of patients have for me is, is this the actual size of the implant? Some components of this model are, others aren't. So the reservoir is basically the exact size that you see. It comes in two different sizes, but for simplicity, yes, this is about the size of the reservoir that's used, and likewise, this is the size of the pump. On the pump here, you can see the deflate button on the top. The bottom is the inflate. So in order to inflate the device, you're going to squeeze it. You can see that I'm squeezing the pump and I'm collapsing that. The volume of fluid that occupied that pump has now been moved into the implant cylinders. And that's how the cylinders get rigid, is because it's moving that volume there. Likewise, when everything is completed, there's the deflate button on the top. You squeeze that. It's a side press. You press and you hold that for a few seconds, and the implant will drain. As what was seen on that cartoon, if you were to gently squeeze these, you'll just, by pressure, force the fluid out quicker, and now the implant is deflated and you're flaccid. When it comes to the surgical technique for an implant placement, there's two ways to place it in terms of incisions. One that's called a infrapubic incision, which is an incision kind of on the top of the penis here. A lot of folks, including myself, do what's called a penis scrotal incision, which is an incision right at the base of the penis. And it's about, about a 1-inch incision or so. It's a single incision, and all of the components that you see here are placed inside. All of the sutures are dissolvable, so there isn't anything that has to be physically removed. The only external piece of hardware that most providers, including myself, use is what's called a Jackson-Pratt drain. And it's a small drain that's placed inside of the scrotum, traditionally next to the pump. And it just usually allows normal bloody and inflammatory fluid to be removed so that it's not surrounding the implant. And that's usually taken out between 1 to 3 days after the surgery.
To start us off, since we're talking about advanced ED treatments tonight, our first question is going to be, if one has BPH or prostate cancer that may require a surgery, should that be done prior to having an implant placement?
Yes. So there's been a debate, whether these should be done before or after. And a lot of that has to do with what the function is going into surgery. And I think that setting expectations are very important. So traditionally speaking, if you're very potent, you have no issues with ED going into one of these procedures, then it's safe to assume that you may have mild ED afterwards. Conversely, if you're entering into surgery with already some substantial component of ED, then it's likely that you may leave needing an implant or ICI or some sort of advanced therapy. That result is not guaranteed. So one of the things that I, as a provider, would not recommend is having one of these things placed beforehand if you don't need it otherwise. So if you're taking Viagra, you're taking Cialis, you're getting a good result with that before one of these prostate procedures, I usually just advise just see how the chips fall, see what your function is afterwards. There's no ill or adverse consequence to having this done later. The only thing to note is that if you're having issues with ED immediately after one of these procedures, you want to be pretty aggressive about this, because men that let this problem go on for a very long time can develop some degree of atrophy of the penis and permanent shrinkage. If you're aggressive, you know about the risks of these things going into one of these procedures, and you're monitoring and you're following up with your healthcare provider, that's less of an issue going forward.
Certainly. Alrighty. I believe that answered our next question as well, which is going to talk about the optimal time frame post prostate removal to get an implant. So we basically covered that there. We'll move along to our third question here. So how long after prostate removal surgery should one try pills or injections before considering moving on to the penile implant surgery?
So again, that's a little bit of a conversation of what your function was going into it. So let's just take a man who has no ED whatsoever, and they go into this process. We usually advise immediately after surgery to begin some sort of erectile therapy. We call that penile rehab therapy. That's something that usually takes place immediately after the prostatectomy. That usually involves a daily oral medication, a daily Cialis, or a daily Viagra. And I will often have my patients use a vacuum erection device, because in the event that you're not getting good erections, using the vacuum erection device will allow new blood flow to cycle the penis. If you look at the literature on recovery of erectile function after either prostatectomy or radiation therapy, they're usually roughly about the same. They're usually between, at most, 2 years of recovery. Now, in my practice, I have found that most of the spontaneous healing to the erectile mechanism occurs after 1 year of healing. But I have individuals that, for example, maybe entered into their prostate cancer journey with very poor erectile function to begin with. And so I'm more aggressive about those patients. In general, I'll start to bring up the conversation of an implant no sooner than about 6 months after the prostatectomy.
Alrighty, perfect. Next question here. Is there any difference in recovery time between the, the pump model and the malleable implant model?
They're roughly about the same recovery, because they both use a single incision at the same area for the same amount of time. Where they vary is in terms of the recovery is because when you have only the implants put inside the penis, there's a shorter recovery for that because they're contained within those deeper penile structures. Most of the recovery is usually from swelling that occurs in the scrotal compartment where the pump is placed. So the more components that are placed inside the scrotum, which is the pump, the more that there's the likelihood for more swelling, because there's been more manipulation in that area. So I tend to find that individuals that have a malleable implant will start to use them sooner, in about a week or two, maybe sooner than an inflatable. But it's really only a difference of about a week or so.
Alrighty, and running up to our final question with the implant procedure, can you talk a little bit about the size, I guess, before and after? Does someone lose penis size, and what about sensation as well?
That's a great point. So to tackle the second part of that first, all of the compartments of the sexual cycle are all individualized. So the neurologic pathways that govern erections are different from the neurologic pathways that govern sensation, which is different from that of the feeling of orgasm, ejaculation, and et cetera. So they're all individualized things. So when you put in a penile implant, or for that matter, if you were to use injectables, it's only going to give you an erection. The sensation's unchanged. After prostatectomy, you'll have dry orgasms. That's unchanged as well. All these treatments, between the injections or the implant, they only seek to achieve the erection. The rest is on you, so to speak. In terms of expected size, that is a function of a number of different things. So as I alluded to in one of the prior questions, if a man who unfortunately is not well educated in terms of these treatment options, is not aggressive, and they've gone years and years and years without having good erectile function, that can cause permanent shrinkage of the penis, and that's something that is largely an irreversible process, which can account for differences in the size. Now, the intracavernosal injection will give you your natural erection, but with the mechanical erection that's generated by the implant, it's by what we call stretched penile length. So the way that the implant is placed into surgery is your penis is taken and then it's stretched for as long as it can possibly go, and then the implant is fit to that size. So the right expectation to have is if you were to take your penis as you have now and pull on it as far as you can, as high to the sky as you possibly can, that's going to be what the penile implant is able to achieve.
Very good. I've definitely heard that analogy before as well. We have one more quick question we're going to ask about ICI, because we just covered a lot of implant questions. So will ICI work for someone with venous leakage from a prostatectomy?
A great question. The answer is yes and no. Venous leakage is a particularly troublesome issue. I spoke earlier in terms of the etiology of vasculogenic ED, that it could either be an inflow problem or an outflow problem. It really depends upon the degree of venous leakage. So when somebody undergoes a Doppler study, and that's a situation where the penis is injected with a trimix or bimix, et cetera, and then the practitioner performs an ultrasound evaluation where they're able to see the pressures of the inflow mechanism, but also the resting tone of the vessels to see what the backflow is. If you're able to use an injectable dose that's high enough to bring enough blood flow into the penis that then can cause compression of those vessels, that can sometimes help with a mild degree of venous leak. If the degree of venous leak is moderate to severe, then unfortunately probably the injection won't be able to overcome that. However, in individuals that are motivated to avoid an implant, I have often had them do injections with the use of a penile constriction band. So the injection will allow, as long as the arterial input is not damaged, it will bring the new blood in, and then by using a constriction band on the base, that will act to augment the trapping, especially in the case of a venous leak. And I've had good success with that. And so that's one way to try to combat that, even if you're motivated to avoid the implant, but the injection might not be powerful enough to overcome a more severe leak.
First, we would like to thank our sponsors tonight, Coloplast. Coloplast is the maker of the Titan series as well as the Genesis series of the implantable penile prosthesis models we looked at tonight that both Dr. Amend and Bob spoke on. So thank you very much to Coloplast for making this event possible. If you'd like to learn more, you do have a few options. There are more ED resources in the Resource Center on menMD.com. You can visit this page to view instructional videos, guides, expert articles, and more. If you'd like to learn more about the implant options we spoke about tonight, available through Coloplast, you can get answers to common questions like insurance coverage by visiting coloplastmenshealth.com. Exclusive to menMD members, you can also book an appointment with a treatment specialist by logging in and creating an account on the menMD new portal. You can also call in at 857-233-5837. That'll be your best bet to get any follow-up questions answered.
To get in contact with me to either have a discussion of a personal case of yours or how that I could help best treat your ED, there's a couple different ways to get in contact with me and to book an appointment. You see the number on there. That's a dedicated scheduling line for my practice. So my patients don't have to necessarily navigate through a phone tree, so to speak. But it's the number there, 917-763-4635. Or alternatively, for individuals that are more akin to a digital platform, you could go to my personal website there. It's myname.com, gregoryamend.com. And there's not only information on there for patients that cover a lot of what we discussed tonight, but there's also forms to fill out for appointment bookings as well. I'm located in the Upper East Side of Manhattan at 5 East 98th Street through Mount Sinai Medical Center.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.